Why do I need to know if my patient is depressed? You may say, I'm not a psychologist, I'm not trained to diagnose depression, and even if I think someone is depressed, I can't manage it. Anyway, patients will likely seek attention from a specialist, or at the very least their primary care doc. Let's deal with those assumptions. As we will see, screening for depression does not have to lead to a diagnosis of depression, only a high enough suspicion for referral. Many patients actually don't know they're depressed. Focusing more on the physical symptoms of depression, they seek attention for those symptoms rather than depression. First, it's important to know that depression represents the second most common chronic condition seen in primary care, and as we'll see, it affects our patients' response to care and risk for chronic pain and disability. There are some natural assumptions that either a depressed patient will let me know if they're depressed or will have already had that discussion with their primary care MD. Unfortunately, this is more often not the case. Secondly, it's natural to assume that if the patient was depressed, they could explain why. And finally, it's assumed that patients who don't seek help and who are depressed are not that bad off and will simply get over it. We all can recall a stressful event or a scenario of loss that we eventually, through time, overcame and returned to our usual selves. Unfortunately, this is not true for all individuals. Again, why does it matter? A misdiagnosis of depression affects the entirety of a patient's life, including their risk for chronic pain, and the vicious cycle continues, where chronic pain becomes a facilitator of continued depression and vice versa. The literature over the last few years has given strong evidence to the fact that chronic pain and depression are a profile for the patient with recurrent and/or disabling pain, regardless of whether it's spinal pain or extremity pain. In fact, depression is one of the strongest predictors of either having spinal pain or extremity pain, and also a predictor for recurrence and disability. If you're still left with the feeling that based on your own history of depression related to a reaction to a sad event in your life, that depression will go away with time, you're reflecting on only one type of depression felt by most humans. This represents only one of a continuum of disorders related to depression. It's referred to as an adjustment disorder. In the past, it was also referred to as a reactive disorder and also exogenous depression, referring to the trigger being outside oneself or situational. The patient often can pinpoint exactly the cause, and it's more often than not self-limited. The most common general reason is loss. This loss could be loss of a spouse, loved one, financial or employment loss, or other similar investments. Although there are obvious neurochemical reactions to this depression, usually by 3 to 6 months the individual is back to normal. But what if the depression is either more disabling or longer lasting without necessarily an identifiable cause? This is more likely a manifestation of a more significant kind of depression, unipolar depression. Unipolar depression is likely due in part to the dysfunction or imbalance of internal mediators of mental and mood function, including neurotransmitters. There are two forms representing different degrees of severity. The most severe is called a major depressive episode. The other is less severe but chronic, called dysthymia. The combination or alternating occurrences of depression and mania refers to the other category, bipolar. Bipolar depression is divided into two types. Bipolar 1 is dominated by manic episodes, whereas bipolar 2 is dominated by depressive episodes. As with major depressive episodes, a bipolar disorder can manifest clinically as a mild or chronic disorder called cyclothymia. Manifestations of mania include euphoria, hyperactivity, inflated self-esteem, decreased need for sleep, increase in goal-directed activity, distractibility, and participation in risky activities, especially financial. Although we see depression categorized into distinct entities, depression expresses itself more often as a spectrum of disorders with overlap. This spans the range of minor or brief and recurrent depression to constant, mild, or severe depression. The causes of depression are multifactorial with different interactions of these factors in each individual. What is known is that there is likely a genetic predisposition related to, among others, serotonin receptors. This then, to some degree, determines an individual's reaction to stress, a biological genetic factor. Interacting with this is the individual's inherent or learned responses to stress. Social factors related to lack of resources for supportive relationships, financial stability, and poor access to healthcare resources also can be important. These three general categories are weighted differently for each individual, but likely contribute to an individual's risk for depression and its recurrence. Looked at a different way, an individual has a certain degree of vulnerability based on the cards they're dealt genetically and their attitudes toward the world, which when challenged by stress may lead to depression. Additionally, after an initial episode, biochemical changes occur, which may then predispose the individual to future occurrence. So how does stress factor into the equation? Well, stress, acute or chronic, appears to be the catalyst for an initial episode. However, it appears that for those with chronic depression, stress becomes less obvious as an initiator, presumably because neurochemical and behavioral changes have occurred that put the individual at higher risk for a recurrence, not requiring an obvious stressful life event. Let's look at what current evidence suggests regarding stress and its relationship to the brain and depression. With acute stress, the cortex sends signals to the amygdala. The amygdala is prompted to release corticotropin-releasing hormone. CRH stimulates the brainstem to activate the sympathetic nervous system. Sympathetic activation causes the adrenals to release epinephrine, and a separate pathway causes the release of glucocorticoids. Then with chronic stress, glucocorticoids prompt the locus coeruleus to release norepinephrine, and then norepinephrine stimulates the amygdala to release even more CRH, and the cycle continues. Some of the possible effects of chronic stress and subsequent symptoms related to depressed mood are based on specific changes in the brain. For example, the release of glucocorticoids, epinephrine, and norepinephrine may decrease levels of dopamine, worsening mood. Decreases in serotonin in addition to depressed mood may lead to symptoms related to increased sensitivity to normal stimulus and also has effects on sleep. It is known that with chronic depression, there's a decrease in the size of the hippocampus, which is particularly important for its effect on memory. In fact, depression in seniors often causes such a dramatic effect on memory it's referred to as pseudodementia and can be mistaken for Alzheimer's. Whatever factors or group of factors initiates depression, the effect on neurotransmitters is dramatic. There are several hypotheses about these effects, and in fact, these hypotheses form the basis for pharmacological treatment of depression. Now, in simple terms, looking at the level of an axon terminal, vesicles bind to the presynaptic membrane and release neurotransmitters into the synaptic cleft, where they are potentially taken up by their corresponding receptor. The different hypotheses are based on either how much neurotransmitter is released, how many and how sensitive the neuroreceptors are, and finally on what happens to the neurotransmitters with regard to breakdown or reuptake. Here is a simplified graphic of normal release. You can see that much of the neurotransmitter is coupled with its receptor. Some is not, and then can be broken down by primarily monoamine oxidases. Some is also captured back through transporters that allow reuptake. Some of the medications developed for depression work on blocking one or the other of these processes. Monoamine oxidase inhibitors block the degradation of the major neurotransmitters. Tricyclic antidepressants, selective serotonin, or serotonin norepinephrine reuptake inhibitors block the reuptake process of these neurotransmitters, making them available for binding to receptors postsynaptically. Now, the problem with this hypothesis as a single explanation is that although these medications can within hours increase available neurotransmitters, the clinical effect takes weeks to occur in most patients. Enter the receptor sensitivity and permissive hypotheses. As a compensatory mechanism to decrease neurotransmitter availability, the postsynaptic membrane receptors may increase in sensitivity, or there may be an increase in receptors. This is called upregulation. Medications may decrease this hypersensitivity or decrease the number of receptors. This is called downregulation, and it takes several weeks. This may explain the delayed reaction effect of medications. The permissive hypothesis is based on the need for a balance among neurotransmitters. In other words, mood is more influenced by the balance of, for example, serotonin and norepinephrine rather than their actual levels or number of receptors. Low levels of serotonin then permit abnormal levels of norepinephrine to cause either depression or mania. Well, now back to the patient. How do I know if my patient's depressed? First, we must understand that there is no laboratory test or special imaging test to diagnose depression. It's based on symptoms and function. So, will the patient simply say, "Doc, I'm feeling depressed"? Well, actually, they're far more likely to sound like this. "I'm tired all the time, my back hurts, and I have trouble sleeping." Well, here's the major problem with recognizing depression in your patient. The presenting complaints of depressed individuals is not the same with primary care doctors as it is with psychiatrists. Fewer than 10% of patients who are depressed complain of mood disturbance. More commonly, patients present with complaints related to chronic pain, somatized complaints, vague complaints, multiple complaints, often related to anxiety or vegetative symptoms, such as insomnia, loss of appetite, fatigue, or weight loss. Other concerns are memory loss, inability to concentrate, or having difficulty with making decisions. In fact, when evaluated using a measurement tool called the Hopkins Symptom Checklist 90, patients with high depression scores tended to have other complaints other than depression or sadness. The odds ratios for depression were highest in these patients for fatigue, sleep disturbance, multiple complaints, and nonspecific musculoskeletal complaints. Also reported often were back pain, shortness of breath, gastrointestinal complaints, and dizziness. Well, now you see the dilemma. Each of these could be a real and separate complaint, but taken together, even without the expression of sadness or depression by the patient, depression should be suspected and evaluated. Part of the explanation for the contradiction to our assumptions is that depressed patients may somatize. What does that mean? Somatization is not a diagnosis per se, but an unconscious psychological process of expressing psychologic distress such as depression as physical symptoms. In a sense, a conversion of a mental stress to a body symptom. There is a somatoform disorder listed in the DSM-IV, Diagnostic and Statistical Manual, with specific criteria, including a history of somatic symptoms before the age of 30, early age onset is common, pain in at least 4 different areas of the body, 2 GI problems other than pain, 1 sexual symptom such as erectile dysfunction, and 1 pseudoneurological symptom as seen in conversion disorders such as fainting or dizziness. However, many disorders are associated with somatizing. Depression is only one of them. So how do we know that it's likely depression? Some recommend an open-ended question such as the HATA approach. How are things at home? This may open dialogue regarding depressed feelings or the effect of depression on function. Next, the DSM has set out criteria which include 9 indicators. 2 are more psychological reflections of depression, and at least 1 needs to be present. The remaining 7 represent a split between physical symptoms and other psychologic symptoms. The requirement is that in addition to a depressed mood and anhedonia, 4 out of the remaining 7 symptoms must be present for at least 2 weeks. Some of these may be surprising, including sleep disturbance, which includes insomnia, or early morning awakening. Loss or gain in weight, although loss of weight is more common. Psychomotor retardation, causing some patients to describe movement as slowed down, and memory loss is common. And of course, low self-esteem and suicidal thoughts. Depression is probably one of the major causes of low energy or fatigue. Now, if we simply pull out the 2 symptoms of depressed mood and anhedonia, which translated means loss of interest in life and usual pleasures, the sensitivity for uncovering depression is 96%, which means it's unlikely to miss anyone with depression if neither is present. The specificity, though, is 57%, meaning that other causes need to be considered. Starting with the first 2 questions is the basis for what is called the Prime MD2 questionnaire. If positive, use of the Patient Health Questionnaire, the PHQ-9, will more clearly ferret out who the actual depressed patients are. So what is the PHQ-9? The Patient Health Questionnaire is the next step in screening. It addresses the first 2 questions on mood and anhedonia, but then it asks questions regarding the other 7 symptoms and the effect of these on function in life. You can see the scoring approach here. The rating would be 0 to 4, no depression, 5 to 9, mild depression, 10 to 14, moderate depression, 15 to 19, major depression, and 20 to 27, severe depression. Please see the link on the homepage of this video to the PHQ-9 to see how these questions are asked. Let's now put this all together. Let's look at the prevalence of major depression in primary care. It ranges from 4.8 to 8.6% or so. For dysthymia, it's about 2.1 to 3.7%, and of course, there are other types of depression. Risk increases by 1.5 to 3.5 times if you're female, and for patients with chronic medical illness, chronic pain, recent life changes or stressors, fair or poor self-rated health, and unexplained symptoms. Let's use an example to illustrate how you might use this in a stepwise approach and the resulting predictive value. Let's assume a prevalence between 7 to 12%, and remember those factors that increase the risk of depression by 1.5 to 3.5 times. Now, let's use a single question of, are you depressed or sad? A no answer would decrease the likelihood of depression to between 6 to 12% depending on the associated factors just mentioned. A yes answer would increase the probability to between 20 to 37%. Not very definitive. Let's see if we can do better. Let's use the prime MD2 question approach. A negative result on the two-item question means that the likelihood of depression is only 1%. Patients who score positive and also have a score of 10 or higher on the PHQ will have a probability between 49 to 59%, high enough for referral. Those with a score less than 10 only have a 1 to 4% chance of depression, so it's unlikely the patient's depressed. Well, now that we have a sense of whether the patient's depressed or not, let's recall that the patient may have primary depression or secondary depression due to an associated disorder. Here is a list of some of these disorders, which include chronic renal, cardiac, cortical, and hormonal disorders. Next, let's also consider the effects of medication on mood. Look at this general list of potential medication-related causes of depression and determine if your patient is taking any of these. If so, this is important information in the referral communication to the prescribing MD. This leads us to the medications utilized in the management of depression. We've already covered the general mechanisms of these medications when we discussed neurotransmitters. Well, here they are, including the major categories of tricyclic antidepressants, reuptake inhibitors, and monoamine oxidase inhibitors. Many patients are also placed on anti-anxiety medication. For manic depression, the mood stabilizer lithium is still used. However, there are newer medications listed here that are also in use. Because tricyclic antidepressants are non-selective, they also block other postsynaptic receptor sites, including cholinergic, muscarinic, histaminergic, and adrenergic receptor sites. This causes common side effects when these medications are taken. The side effects of histaminergic receptor blockage are potentially sedation, weight gain, and hypotension. This is particular concern in the elderly where orthostatic hypotension causes fainting or falls, which may result in fracture and even death. Tricyclics also block muscarinic receptors, in essence, blocking the parasympathetic nervous system. Symptoms may include blurred vision, dry mouth, constipation, urinary retention, confusion, and delirium, again of particular concern in the elderly. Certainly, it's also important to know that these drugs may interact with other drugs and that polypharmacy is common in the elderly. Some might wonder what evidence exists for the use of non-medication treatment. Well, starting with exercise, the evidence is fairly strong that continued exercise can be as effective as psychotherapy, which is as effective as pharmaceutical approaches, at least for mild to moderate depression. It doesn't seem to matter what type of exercise, but more the commitment to regular exercise. Some obvious benefits are increases in serotonin and endorphins, but also improvements in self-esteem. A recent Cochrane review came to similar conclusions, but as usual, the researchers would like to see more higher quality studies. The evidence also suggests that the combination of exercise and medication is better than exercise alone. However, exercise may be more robust in that it can better maintain the therapeutic effect. Well, now on to herbs and supplements. The first consideration is there are potential co-effects using these options with medication that may potentiate or decrease the medication's effectiveness. Here's a list of a few non-drug options with some literature support. Never use these as primary management, and always, when used, do so with the knowledge and approval of the prescribing MD. We'll give a brief overview for each. For tryptophan and 5-HTP, a Cochrane review indicated that they were better than placebo in the treatment of depression. They expressed some concerns about past toxic issues regarding eosinophilia myalgia syndrome. A contaminant known as PEAK-X was found in several commercially available tryptophan products. Check the process used by the company to determine the purity of the product and whether they are PEAK-X free. For St. John's wort, an herb with the active ingredient hypericum, according to a Cochrane review, the evidence suggests that hypericum extracts are superior to placebo for major depression and similar to antidepressants. Interestingly, one study compared St. John's wort, sertraline, and SSRI, and placebo. Look at the results. Placebo beat hypericum in this study and was almost equal to the SSRI. This should remind us that the placebo effect for depressed patients is high, regardless of whether a medication or herbal or supplemental product is used. For omega-3 fatty acids, the evidence in a Cochrane review indicated some effect on the depressive phase of bipolar disorder, but not for the manic phase. A study in the American Journal of Psychiatry indicated that the addition of omega-3s to maintenance medication treatment is an effective adjunct. Another Cochrane review found that depressed patients given folate had a reduction in their symptoms, and in one of the review studies was equally effective as trazodone, an antidepressant. Briefly, it's important to note that psychotherapy may be a very effective approach, and in some studies as effective as medication. Generally, there are two common types: cognitive therapy focusing on substituting negative responses with positive ones, and interpersonal therapy, which works on interpersonal relationships. Electroconvulsive therapy or shock therapy has a negative connotation. However, it has become mainstream in that not only the seriously depressed individuals are being treated, but also those with chronic depression. To dispel a common belief, the patient is not conscious. Some studies indicated 90% success rate over a period of about a month with 16 to 20 or so treatment sessions. Let's review the process of when and how to screen for depression in your practice. Screen patients with chronic disease or pain or those with unexplained musculoskeletal complaints using the PRIME-MD 2-question approach. If positive, administer the PHQ-9. If the score is less than 10, monitor because of the initial response on the PRIME-MD questionnaire. For those with a 10 or higher score, search for clues to secondary causes and contributing factors, including other diseases and potential medication effects. Refer the patient preferably to their primary care MD or to a psychologist. They can better determine the need to refer to a psychiatrist. Consider adjunctive care, but only in collaboration with the treating MD. Because depression may be associated with suicidal thoughts, patients should be referred back to their treating doctor, and if not being treated, referred to a suicide hotline. If the patient has a plan and the means to commit suicide, do not try to manage this situation, but call 911 or call 1-800-SUICIDE or 1-800-273-TALK for assistance. Well, let's summarize. Chiropractors are well positioned to act as safety net screeners for the detection of depression in their patients. Remember, there is no lab test or imaging test to diagnose depression. It's based entirely on symptoms and function. Always be vigilant because depression is often masked through somatization, the conversion of psychologic stress to musculoskeletal complaints. Also be sensitive to the fact that both depression and the medications used for depression affect your patient's presentation and their response to care. Understand that depression is a known risk factor for chronicity and disability. Certainly consider adjunctive care, but only in collaboration with the treating MD, and never attempt to manage depression alone.